Come, Dr. Atul Mathur.
Thank you very much, Dr. Mohsen, for inviting me to this lovely meeting. So today this is a little different kind of a topic we're talking about. My presentations. Yeah. So from so many different types of interventions, now we are moving to the carotid arteries, which are supplying blood to the brain, two in the front, and of course supplemented by the vertebral arteries. They together form the circle of Willis inside the brain. And we know that stroke is a major public health problem, commonest cause of morbidity all over the world, as well as major cause of mortality, the third commonest cause after heart attack and cancer. So this is a reasonably important topic. I'm going to talk about who is a candidate to get an intervention in the carotid arteries. And second, I'm going to talk about how we go about with these interventions. So 10 tips which I'll be talking about. So when you have to choose who is a good candidate, we need to know the natural history of carotid stenosis. And from the natural history, we know that whenever the stenosis becomes more than 75%, the annual incidence of stroke jumps to from 1.3 to 10.5%. So approximately 70 to 75% is the cutoff severity where the carotid causes more risk. Now we know from various trials that in symptomatic patients, whenever the stenosis is more than 50%, the risk of stroke is significantly high. So that is one important issue. And in asymptomatic patients, more than 60%, the risk of stroke can be reduced by intervention. So these are the trials which we have. So on the basis of the data which is available, the guidelines have been raised. All symptomatic patients, more than 50% carotid plaque have to be treated. And second, in asymptomatic, that those who haven't had a TIA or a stroke, more than 80% stenosis is accepted as an indication for treatment, except if there is a contralateral occlusion, or if there is a very ulcerated plaque, or if there is a silent infarct on the CT, you can also treat more than 60%. Important thing is that you should not be causing a higher incidence of neurological complication during your procedure. So there's a lot of debate. There's another option of surgical endarterectomy, carotid stenting to treat these carotid stenosis, and medical therapy. So the debate will still continue as the treatment modalities are evolving. So I'm going to see what are the kind of cases which you need to avoid for stenting and what are the type you have to avoid for surgery. So certain kind of cases are very high risk for carotid stenting and you should avoid treating them, especially if you have an adverse aortic arch, very tortuous vessel, extensive disease in the common carotid arteries, a heavily calcified lesion, long lesions in the carotid arteries, and presence of a large piece of thrombus. Better send them to your cardiovascular surgeon to treat. Similarly, the surgeon will have a lot of problems when there are bilateral carotid stenosis, contralateral occlusion, or severe coronary artery disease is existing. At times, anatomic problems like high or low lesions, short neck, post-radiation fibrosis, and restenotic lesions also pose a challenge to the vascular surgeon. So if you look at the indications, guidelines, less than 50% carotid stenosis or total occluded carotid stenosis or a severely disabled person should not be intervened upon. Now, if you have a symptomatic patient, he's high surgical risk, stenting is definitely superior to surgical endarterectomy. If he's a normal surgical risk, then you have to see the patient anatomy, patient preference, and the expertise of the person who's performing. Similarly, in asymptomatic patients, also in high risk stenting and in normal risk, you can choose between stenting and endarterectomy. So now we go to when you have a bilateral carotid stenosis, which one will you treat first? So you have to treat the symptomatic carotid stenosis first, and then if you have an asymptomatic carotid stenosis on both the sides, then you will treat this more severe stenosis first, or the vessel which is more dominant, which is supplying both the hemispheres, or the one which has a heterogeneous plaque or the one which shows silent brain infarcts in its territory. So this is how you have to choose between which side to choose if both are silent, where they've not been symptomatic. And when you have to treat the two, you should ideally stage them by 2 to 3 weeks. So here was one of the cases who had tight 99% stenosis of both right internal carotid, left internal carotid, right vertebral artery ostial, and he was presenting to us with recurrent syncope. So he ultimately was treated for the right internal carotid artery, staged to be treated by a left internal carotid artery stenting after a period of 4 weeks. So this was the result on the left carotid artery. Now when you come to a situation where you have common disease in the carotid as well as severe disease in the coronary arteries, so we have to see whether the carotid stenosis is symptomatic or not. If the carotid stenosis is symptomatic, then you need to see if the angina is stable, then you fix the carotid first. If the angina is also not stable, then you need to do a combined hybrid kind of a procedure, do a stenting in the morning and do cardiac bypass surgery in the evening, or do a carotid stenting and coronary angioplasty at the same setting. If your carotid stenosis is asymptomatic, then you leave the carotid alone, let the bypass be done or the coronary stenting be done, and then address the carotid later at a suitable date after 3-4 weeks. So this is how we treat the combination of this disease. Now, if you look at the appropriate working view for people who are starting to do carotid angiograms, the LAO view is the best view where you will open up the arch. If you try to see and engage your arteries in the AP view, they will overlap each other. And this is how you see your carotid bifurcation. Once you have engaged your diagnostic or a guiding catheter inside the common carotid artery, you go to an extreme LAO view, and there you will be able to see the internal carotid going posteriorly behind, and usually the lesions are lying at the carotid bulb, which is located over here. So at the beginning of the internal carotid artery, the plaque is placed posteriorly mostly. So access of the carotid arteries is the most difficult part, and number of times you cause a complication of stroke if you have a very tortuous access in the carotid arteries. Sometimes with the advancement of age, the type of arch will start getting more and more complex. The innominate will originate more and more lower as compared to the roof of the aortic arch. And there you have to, if you are going by femoral route, you'll have to take a very tortuous course and do a lot of manipulation in the carotid arteries. So you need to be seeing what kind of arch you're dealing with. Number of times you may get a bovine anatomy, again where the left common carotid artery is coming out of the innominate artery. It's not a very easy access, so you need to be aware of these two things. When we go to vascular access and the use of guiding catheters, the commonest catheters you use to get into a carotid artery is the JR catheter, the coronary right catheter. And sometimes if you have access to the VTEC catheter, it's a very good, useful catheter to get into the carotid arteries. A lot of people prefer to do their carotid stenting procedures using a long sheath. So how do you get into the carotid artery with a long sheath? You go with a diagnostic catheter, pass a wire up into the external carotid artery, advance this diagnostic catheter up into the external carotid artery, get a stiff wire across this external carotid artery and remove your diagnostic catheter, and over the stiff wire you advance your sheet into the common carotid artery, and then you perform the procedure. If there's a tight stenosis over here, you cannot go into the external carotid artery. You can roll this stiff wire somewhere over here so that you don't have to cross the lesion. Similarly, some people use guiding catheters to get into the carotid arteries, and that is when you have a very difficult anatomy. You can place your guiding catheter at the mouth of the common carotid artery. So this is an example of a situation where you don't have enough support. You can use a buddy wire in the external carotid artery to give support to your structures. And a special catheter called the Piton catheter was being used by us, which is not available in our country right now. I have a US patent for a carotid access system where you get an extra support from the floor of the aortic arch to get into the carotid arteries which have difficult anatomy. And sometimes you need to do these procedures from the brachial or the radial route, which is a very easy procedure, especially if you have very difficult anatomies. This was a tight lesion. You went from the right brachial, did your filter deployment, the stent goes up, and you got a final result. So some people have thought about transcarotid flow reversal technique also, where you puncture the common carotid directly and perform a procedure there. It is supposed to cause the minimum embolization because you don't have to scratch the arch of the aorta to get into the carotid arteries. So finally, neuroprotection is a very important issue. Lot of debris. This is all debris which will go north into the brain. And you have seen that with use of neuroprotection, you have significantly reduced the risk of stroke in these patients. You can either use a filter device or you can use a distal protection MoMA device. This is one of the cases which I did with a MoMA device where you have protection, a proximal occlusion in the external carotid, and then you perform your procedure when there's no flow. Stents have evolved over a period of time, and you've got some special mesh-covered stents being used. Some complications need to be avoided, which you should know. You should be ready to tackle with a clot which goes up into the brain. During your procedure, you have to monitor them neurologically and deal with them. So you have to remember carotid stenting is an alternative to endarterectomy, but it is not possible in every case due to limitations in technology and sometimes adverse anatomy of the patient. Thank you.